To day 4 at the Kapil booth. And today we have the Mammo AI panel being moderated by Dr. Helen Fraser. In the panel, we have Dr. Ambika Seth from Lunit. We have Brian from Deep Health, Thomas from Therapixel, Kevin from Qmatrix, and Peter from iCAD. So over to you, Dr. Helen, to get started.
Thank you very much, and good morning, everybody. Very exciting to be here for the panel today. I think you'd all agree it's been an amazing conference with so much breast AI featured, which is absolutely wonderful as one of the front runners of AI and radiology. So I've got a bank of questions for the panel. Hopefully we'll have a bit of fun. I know that you're all competitors, so thank you for coming along today. So I think we'll get started on that note. So you're all providing Mammo AI solutions for early detection of breast cancer. And I'm really curious to understand what your point of difference for your company is. So this is your moment for your 2-minute pitch. So if you can take it away, we'll start with you, Ambika.
Thanks so much, Helen. So as you know, Lunit has a partnership with Volpara. And together with Volpara, our companies are pretty financially stable. We have invested more than $100 million in R&D to make sure that our products are top of the line. Also, when we talk about AI, data is really important. We have access to more than 130 million images from the US population. Also, dense breast data from Korean women. So that's two good things. Our products are backed by clinical evidence. We have more than 400 peer-reviewed publications. And we are a truly global company because we have customers in more than 14 countries, more than 7,000 happy customers. But we also know that regional customers have their own needs. And that is why we have boots on the ground, customer success teams on the ground, making sure that all the customers are happy. Yeah, thanks.
Hi, Helen. Thanks for having us. We've taken a different approach to this. I mean, I sit here amongst all of our august competitors who are doing a fabulous job on breast AI. And although we've been around as a company for 11 years and have been focused on AI and mammography for all that time, and we have our breast AI products, we're not focusing there at all. In fact, what we're doing is focusing on our CM Angio product that detects breast arterial calcifications in the mammogram. And instead, in fact, working with our competitors in a partnership model to help bring this forward to the market so that more women can benefit from this. And, all of these competitors are great. You guys have huge market shares, and for me to try and go and, claw away at pieces of it just doesn't make sense. And it's actually not good for our market in general to try and out-compete on price. That doesn't help any of us. And when you look at all of our AUC curves, give or take, they're all in the same place. I mean, that differentiation doesn't exist. So I'd rather work with folks who have built a strong brand and a strong market and help bring an additional product to the market in their package under their portfolio that gives them the benefit of those pieces of revenue and a new offering for their customers.
Thank you for hosting. I totally agree with Kevin. Everyone here has great solutions. I think the approach we have taken at Therapixel is really to focus on a solution. So this is where we will probably differ a little bit from the other solution, but like performance-wise, I agree there's a lot of good things here, and competition make all of us happy because we can raise the price, compete a bit. But we have just released this year a solution that really cover the entire workflow. So from work list management to image quality to density to, of course, comparison with priors. We've been doing that for 3 years now, and so we also help providing a pre-reporting. So the idea is really to streamline the workflow and reduce first the time spent on images, because we all know that we want to have good performances, but also a big issue is making people more efficient. And we just announced also that the next generation of Hologic Genus AI Detection Pro is backed up by a whole solution. So we'll be white labeled whole solution to the Hologic new AI. So that's a big win for us this year, and we're really happy to engage this partnership.
Thank you very much. Now across to Peter.
Thanks, Helen. Can you guys hear me okay? So I think a couple of things are interesting is that ICAD was probably the original founder of all this information that's been flowing around for a long time. And I think the answer of one of our solutions is workflow. There's a huge issue in how do we get workflow to work for the radiologist as well as the entire healthcare system. So on-prem servers, cloud servers, all those types of operations are super important to actually getting the product to work. As far as products go, the key part is many of us have overlapping areas that we work in, but getting US-based data from a US-based company, we're probably the only US manufacturer of this operation, and then being able to help that data get back to the population as well as build new algorithms. So a strong publicly traded company that's supporting new algorithms, building new technology, and to Kevin's point, working on things like BAC and future cardiac risk and so forth. Those are all areas that not only do some of us collaborate on, but we also compete in. So it's a great market because I think about 15 years ago when the AI side of RSNA was literally the back wall over here with little tabletops, it's grown pretty dramatically. So this is clearly a solution that's here to stay for all of healthcare.
Can you hear me okay? Okay. So I'm picking up a theme of it. Mammo AI panel is really not just AI. It's there's more than AI here. Deep Health has gone through a transformation as well over the last year or so, where we're now offering fully integrated solutions. We announced at RSNA a smart Mammo solution where we're integrating our cloud native viewer to help speed up efficiency in addition to the tightly integrated AI tools that provide clinical accuracy as well. And the feedback that we're getting is, how did we ever live without this before? I'm putting on glasses and realizing I didn't have glasses before, and now I don't want to go back.
Thank you, Brian, and thank you all of you for your wonderful insights. And now we actually have deployments. The focus shifts to quality assurance, which we know is a critical dimension for safe use of AI in breast cancer imaging. So I would be really interested to understand your approaches or recommendations to quality assurance. And this time, I'm going to start with you, Brian.
One of the things I didn't mention at the beginning is that as Deep Health is, our parent company is RadNet. And so they're a large provider in the United States where we deploy all of our AI across about more than close to 400 clinical sites. And one of the things that we've learned is there is importance to monitoring the AI. And we're working in partnership with people like Carpal and so forth on that. There's also an importance to monitoring what the users are doing and optimizing their use of the AI. It's not, I think we've all learned you don't throw AI over the wall. To get the results you need, it requires a feedback loop. And so we're working on some of our AI monitoring, but also the clinical safety monitoring as well. And we're developing that inside of RadNet, and then we'll be taking that out outside to our external customers in the future.
So I think some of the important parts of quality is training. You have to be able to make sure the facility is trained properly, they're using the AI properly, and not every radiologist reads the same way. So you have to make sure that it works within their variance on how they read. The important part from an FDA, we're all FDA approved products, and making sure that we're doing the most stringent FDA approval as we can possibly do. I want to make sure that every vendor that we work with and every partner that we work with has all those approvals. And realistically, to your point, is that we want to make sure there's a growth for every one of our opportunities to say, what do you need in your next product? And how can we make that not only as safe and as quality related, but how do we build that next generation for you?
Thank you.
Yeah, to Peter's point, all of us are FDA cleared, and so there's already a layer of security on all our algorithm. And the FDA recently has been much more careful around the bias, and they ask data on ethnicity and race. So there's the first layer. The big next question will be, how do we make sure there's no performance shift over time? At Therapixel, we've taking an approach, at least first on the distribution of cases. because we all have some scoring, and so we all say previously to integrate a product, this is what you should expect. And so we actually take this data in real life, and we make sure they are aligned with the actual performances that we claim. And so we have a dashboard for that where you can actually monitor that. And we did publish one paper where we've tested that in 3 US sites, and we made sure that the actual prevalence of cases compared to what we are claiming in the FDA regulation was accurately and about the same. And so we actually showed on these 3 sites that the expected distribution was the one that we claimed for. So that's good. And so over time, we will make sure that every single version will continue to respect this distribution, or at least be better.
For us, it's been an interesting journey. As I said, we've been around for 11 years, and we were actually the first company to get cleared by the FDA to do AI many years ago on a mammogram. And so we've been working in AI on mammography for a long time. And in parallel to that timeline, we've been building out our DevOps in the back end. So we have a very, very sophisticated and robust architecture for how this software gets deployed and managed, combined with a very sophisticated and robust means for how we develop the software. And then as we put this out into our customer side, we work hand in glove with our customers to make sure that as they understand more about what the product is or isn't doing in their world, we're also comparing that in time to what we see on the back end of their cases. And then we have meetings with our customers. So we understand, here's what we're seeing in your data. What are you seeing in your data? Are we aligned? Are we out of sync? So quality isn't something that we own. It isn't something that they own. It's something we own together to make sure that what we're delivering to the patient is of the highest potential quality.
Yeah, so we talked about the FDA clearance, and all the products here are FDA cleared. So the products have a performance that's at least on par with the radiologist, or sometimes exceeds them in certain domains, and sometimes it does not. However, the thing is, when we look at the validation on our internal data sets, the performance at times can be higher than what is seen in the real clinical world, and vice versa. So we need to focus on 2 things. One is the domain shift, and the other is drift. As Peter mentioned, so what do we mean by a domain shift? It essentially means, let's say the data has been trained on Asian women with dense breast, and if it is deployed on, let's say, American women with on an average lower density, or let's say it has been trained with Hologic and it's deployed on GE devices, then the performance can vary. The other thing is the drift. So let's say the AI solution is deployed in one institute, and over time their population ages, so the density would go down. Or they get in a new vendor, that would also lead to a change in performance. So how do we mitigate these 2 factors? There are a couple of things that we do. First, as you mentioned, when we train our algorithms, we make sure that the data sort of generalizes well. We include different breast densities, different populations and vendors. Secondly, when we do both internal and external validations, we do pretty stringent subgroup analysis to make sure that the performance is good enough across all the different groups. And lastly, we are coming up with something called the Insight Manager. That is like an analytics dashboard, and will give live updates to the customer. So they'll be able to see the AI trends, the performance. Also, they'll be able to set alarms. For example, let's say if the AI positivity is more than 10%, that would raise an alarm so that they can reach out to us. We can, look into the problem, where exactly is the issue, and then solve it. So this Insight Manager would give more autonomy to the customers. They can make informed decisions, and it's all going to be live. So there's not going to be any lag in the data performance and what they see.
Thank you very much. That's terrific, and everyone's got a keen lens on AI that's safe and fair for all. So that's all wonderful to hear about QA approaches. The next question is trying to understand your approaches to applications that involve breast cancer screening, where there's a very low tolerance of harms. Will women coming for early detection of breast cancer as opposed to women that are going down the diagnostic pathway where they've got a problem to be solved, a nipple discharge, and the tolerance for harms is very different there. So, yeah, I'd love to hear your insights on that. And this time I'll start.
So I guess at least all solutions primarily focus on screening mammograms. So the approach to take here, it's always a balance between sensitivity and specificity. Like, do we want to create too many false alarms and not missing cancer, or vice versa? Obviously, we want it to be sensitive enough so we don't miss too many cancer, but also creating false alarm would recall women for nothing. So it's a difficult balance. We have came up with a green, yellow, red scoring system, and in a sense, the green, the idea is to have an extremely high sensitivity, so we don't miss a lot in the greens, and in the red would be the opposite, a high PPV, so you don't create too many false alarms. And then the yellow part is then for the radiologist to decide a little bit. So you can trust the AI on the extreme, and on the indeterminate cases, they would take their decision. So yeah, that's how we have approached the problem here.
Look, I mean, ultimately, at the end of the day, no matter what any of our software does, the radiologist has to sign the report, right? All of our softwares require that the radiologist is in the loop, looking at the mammogram, looking at our report, and deciding what they want to do with the patient. So the key, as you're noting, is that you don't want to flood the radiologist with false marks, right? Because you can tune the volume up to 11 and catch everything. And you don't want to tune it down so far that you're only catching the egregious ones, which they can see anyways. And so, right? And I lose it. Oh. So ultimately, there's that balance to be struck. But this doesn't actually play out at the tail end where it's most important. What's most important for us, I believe, is at that front end. It's all about how you train the algorithm, what you train it to learn, what you train it to report on, so that when you deliver your report to the radiologist, it aligns with what they're expecting to see. In breast screening, right, they're measured by the MQSA. They want to have a certain recall rate. They want to understand what they're doing with their patients on true positives and false positives and true negatives and false negatives. And we're not going to change that materially. What we're going to do is equip them to maybe make better decisions or faster decisions. But ultimately, they need to make the decision. So we just need to feed them the tools that they have to give them a more informed information.
So our algorithm has been trained for screening mammos, first of all. Secondly, when we talk about validation, again, we ensure we do it on really large screening populations, not just a couple of thousand, but let's say 200,000 plus exams, because that's truly representative of the screening population. It's not enriched with cancers. And also, we focus on recall rates because they are directly related to population-based harms. Now, if you look at our Screen Trust CAT trial, you will see that we have focused on reducing the recall rates. And that is really important because especially in like a double reading setting where they replaced one reader with AI, they wanted to be sure not to increase the recall rate and just bring in more women with false positives. That causes a lot of anxiety, pressure on the system. So yes, recall rate is one thing that we focus on. And again, as everybody mentioned, we also have different thresholds for the customer because every customer is different. Their population is different. Sensitivity, specificity needs are different depending on screening and diagnostics. So we give that flexibility to the customer to test our product first, get to know what works best for them, and then choose their own threshold.
One of the things we found is that it's easier to convince a radiologist that there is something there and they should recall it than there is something not there that they would have otherwise recalled. It's just mentally a different task to say, you may have missed this, and they're grateful that they've caught something that they may have missed. To say there's something that you would have recalled that now you are going to put your name on and not recall is a very challenging thing to convince them to do. One of the things that has helped with that is adding a workflow to the AI. So we've provided the AI to the radiologist so that they can see what it's outputting, but also add another layer as a safeguard where an expert can also double check that. And in those cases, we find where there's discordance, and this could be positive or negative discordance, meaning where the AI has seen something suspicious and it's not recalled, or the AI has said it's not suspicious and there is a recall. And then when we give that to an expert, they're able to work with the first radiologist to help them make the best decision and then get even better results. So one of the things that we've presented at this conference is a 21% increase in CDR. The radiologists are using both the AI for the interpreting radiologist, but also on the back end as a workflow tool to drive an expert review. And then we've also done the same in helping drive down recall rates of high recall rate radiologists. In one pilot, we showed a 40% reduction in recall rate for radiologists who had a recall rate above 12% to start with. So definitely recalls drive harms, as you said. There's more procedures, there's more biopsies, there's more stress for the patient. And we don't want to just be finding more cancers. That is number one, but also keeping in mind those harms and how do we minimize those as well.
So one of the things that we talk about quite a bit is what is the art and science of radiology, right? The art comes from the radiologists themselves. The science is some of our tools that we have here today. And how do we put all those together? Can't just have the AI read and have no radiologist sign off, as you mentioned, Kevin. And you don't want the radiologist just to read without AI. So there is that balancing act between the two. And one of the things that we also talk about is the quality of the actual image. So we try to measure each image for quality by scoring it out and helping the technologists actually get to the best image possible to get the best AI out. So that's where it starts. It's way back in the early part of the food chain of the imaging set. And the more we get that quality, the better, obviously, the AI works for all of us in general. And I think the fact that, to your point, recall rates, we have very similar studies where we've seen recall rates drop 10, 20, 30%. And of course, a problem is where do they start, right? So a cancer detection rate that goes from 4 to 7 is great, but 4 was not very good to start with. So we always try to match that out. And to the point of tracking and analytics and data, you want to try to bring in that data so you can keep evaluating and reevaluating the tool over time. You can't just put the AI solution in and walk away. As to your point, you got to be able to say, it's working this way for you because you have this type of workflow, but yet it works differently for them over there because they have a different type of workflow. So ultimately our goal, and we talk about this all the time, in general statistics, Mammo 6 per 1,000. If we did MR on everybody, we'd be 16 or 20 per 1,000. So there's 10 to 15 cancers floating out there every single day. And those are the ones we want to find earlier. I mean, I think that's the goal of the entire panel, is to help the patient in the end, the radiologist, be more efficient. Most healthcare systems run on a very low margin. So since there's no specific reimbursement, which I know we'll talk about cost and price later, but this is where all these pieces have to come together in quality as well as in trying to do no harm, but at the same time get the most benefit.
Great, thanks, Peter. That's terrific. Next question, a quick one, a rapid fire one. I'll have another one to back it up with. But I am a breast radiologist, and I promise I won't be offended. I want you to be very, very bold. And I'd love to hear your thoughts, or a very quick answer actually, on will AI solutions actually replace me, autonomous AI, or will they help me in 5 years' time? Over to you.
So I think the quick answer is no, you're not being replaced. I think everybody here has probably thought that 10 years ago. We started selling density software 15 years ago, and they're like, I can do it better. And now they want density software, just put it in. Right? So it's super easy. So adoption is great. As we mentioned, this room has changed dramatically. There were 20, 30 vendors 15 years ago. Kevin and I were standing alone over here in the corner, and now it's half the hall. So no replacement, but I think the answer really is that there is a art and science combination of how do we use your skill, your training, your expertise to take every single patient as an individual and use science to help each one of them. Short answer.
Sure. So I want to build on that because I don't know that I've met a radiologist yet who has said, I just love doing density. Don't take that away from me.
Yeah, well, they did
right?
15 years ago.
So it may not be an or question, that there are things that more and more so there are things that are becoming automated that radiologists don't need to do. Maybe there's some hesitancy at first, but often there's gratitude at some point of, I don't want to be spending my day doing density assessment. I don't There are parts of my report. I want an auto repression. I don't want to spend time dictating a new impression. That's not what I want. That's not what I signed up for med school to do. So I think I think we will see more and more automation. I was in a talk yesterday where the speaker polled the audience, and there were very few no's to autonomous AI. There was a lot of maybes, but that's a big shift from 2 years ago, where there were a lot of no's. We're not there. And so I think we are in the midst of a seismic shift in autonomous.
Yeah, I think what's really interesting is that we have human vision and we have computer vision, and they see things differently. So the humans have their own skill set, computer has its own skill set. We need to figure out a sweet spot so that, let's say, there are certain tasks that the AI can automate. For example, let's say reading normal exams, because that might be easier for the AI, just looking at those pixel values, making sure everything is normal. We already have normal report templates, pre-populating the report. So there are tasks that could be automated using AI, and that would essentially free up the radiologist's time to focus on other things, let's say more suspicious exams. There's a huge shortage of radiologists, so sometimes women have to be sent back. They are recalled again another day for further additional diagnostics. That can also lead to a loss to follow-up. So with more time on their hands, radiologists can do the diagnostics the same day. And lastly, I think we have the human touch. So the free time that we get, because the AI is doing the other tasks, we can go to the patient, talk to her, because there's a lot of stress, anxiety in the patient's mind, and just having a human talk to the patient is really great, and that is something AI can't do as of now. So let's just do that.
I think your question's interesting. I want to call it a couple pieces. One, you said 5 years, and two, you said replace all radiologists. And I think that both of those, in a hyperbolic sense, won't happen, right? I mean, I think there's far too much inertia in the medical community to have anything massive happen over a 5-year period. As Peter pointed out, I mean, it has taken us this long to get to here through no shortage of struggle. I mean, 5 years is going to go by like that, and we're not going to see radiologists disappear. Now, on the other hand, if you go back, I don't know, 50, 70 years, when a woman thought she was pregnant, she went into her doctor for a battery of tests. Today, when she thinks she's pregnant, she goes into the bathroom and pees on a stick. But that hasn't eliminated the need for an OBGYN, right? The doctors are still there. I think and the other side of it too is when you look at what I said with all radiologists, I think if you look across all radiologists and all the tasks that radiologists are doing, there are some radiologists that shouldn't be reading mammograms, right? They're junior, they're general, et cetera, but they are right now. So there's an opportunity, I think, to deploy AI to do things that some radiologists shouldn't be doing, don't have to be doing, to change the dynamic of the work structure. Will this happen over 5 years? Again, I think there's too much inertia to actually have it be effective and to have it come into effect. But I do believe that over time, there will be a trust as we can eliminate second reads, right, and double reads in certain communities and prove that that's changing things. If we can change it to the AI being a first read and the radiologist being a second read, there's ways to change the dynamic of the process, I think, that will make it more successful for the patient and their outcomes, more financially beneficial for the radiologists, and more efficient for the system as a whole.
I think I agree with everyone. I would take a bit, maybe, I would engage myself a bit more on that. I would think in 5 years, 50% of the cases could be autonomously read. The negative. There is a law issue in the US because right now the radiologist has to sign the report, but we are at a point in performances where the miss rate in the 50% is so low. So why bother with reading these cases rather than spending more time on the actual tasks that matter that everyone is speaking about? And so getting your time to do other things that are more valuable for the patient.
Thank you very much, Thomas. And it'll be really interesting to meet again in 5 years and see what has actually happened in 1 year. But I do agree, living and breathing in the health systems, that there is a lot of inertia, unfortunately. So the next question, which Peter alluded to, is about the future business model of AI in breast cancer. Do you think AI companies will operate independently, be sold separately, or integrated with mammography machines, integrated into RIS PACS systems, or aggregated on platforms like our dear friends Carpool, or any other options? So yes, Ambika.
I think to get the full benefit of AI, probably they will need to be integrated with Mammo reporting software. For example, we have the patient hub with Volpara and also the EMR, because there are other things such as risk, density that are already out there. Right now, radiologists have a lot of information, but it's all over the place. So it'll be good to have it at one single place, and the radiologist can look at, let's say, volumetric density, short-term, long-term risk, the AI CAT score, and that would help them make informed clinical decisions.
I think RSNA is the perfect living example of the challenge that we face. If you look at the cross matrix, all of the vendors that stand on the floor here, from reporting software to PACS to RIS to NIS to EMR, everything else, the hardware side, to try and when I go into any hospital or all the different customers I talk to, there's no two hospitals that operate with the same matrix. So to think that there's going to be one outcome where all of AI goes into the PACS, and that's the ultimate solution, I think that that's not going to happen, because not every hospital will adopt it in that setting. And unless we formed a coalition where we said all of us are only going to roll through PACS because that's what we want to do. We're only going to roll through reporting because that's what we want to do. We're all only going to roll through platforms. I think it's going to continue to be driven by what the customer wants, as it should be. And I know we will continue to be working to integrate with as many players as we can, but ultimately servicing, if the customer says we want it on Carpool, that's where it is. And that's how we operate.
I think there are two possibilities. Either AI is getting to be a commodity, so it will be integrated in all the PACS reporting. Indeed, there's no real one that would beneficiate more from the other. It can be from the modality at the tech level. We spoke about that for the quality issues. Or either we succeed to change the workflow. And as I was saying, maybe going to the autonomous part of it, and then maybe we can see some companies that actually operate these things. And so it's not through the different vendors, but actually having their own kind of a workflow and maybe operate some clinics and all of that.
So I think the hard part really is that, again, to Kevin's point, you look around here, everybody has something different and everybody wants to do something different. And of course, we all think we're all the best. So with that being said, we talk to dozens and dozens of healthcare systems every week, and they have a slightly different workflow and a slightly different PACS and a slightly different version or an older version of the same PACS that's now out today. It doesn't work to have it to a uniform solution. But at the same time, we all have sort of a diverse way of trying to get it in, whether it's through a platform provider, whether it's through a PACS, whether it's through a workstation, or on a gantry. All those work. And so whatever really, I think we're all in the same mindset of whatever works for the customer, whereas vendors are going to try to do. And so that's probably the easiest of answers. And to Thomas's point, this is where, as it gets more and more mature, the pricing models get better, and maybe you want one, sort of throat to choke, and you go to a platform provider, or maybe you want to work with that vendor directly. So they all work. So your original question, the answer is yes, yes, and yes, and yes. But I think there's just, again, it goes back to that workflow issue we talked about early on, that if you can't manage the workflow and you can't adjust to the workflow, then you have a bigger problem.
Back to it's not just the AI. I think we're all agreed we're not just point solutions, and then the world looks different than it did 5 years ago. We've certainly, I don't know how this is going to play out. I think in the next 2 to 3 years, there's going to be all of the above. There may be some buckets that, things fall into more than others. At this RSNA, we've announced partnerships with Carpool. We've announced partnerships with GE. I think one thing that will happen, one trend that will definitely happen is more integration. And I think And that's something we're betting on, that the tools that were considered separate tools at one point will become more and more closely linked. And that includes the gantry, that includes from your work list to your reporting.
Excellent. Can I just check we've got time for one more question? Yep, we're good. Thank you very much. So look, we're all here for a higher purpose, which we know is to reduce deaths from breast cancer. No. Yeah, to reduce deaths from breast cancer. That was very cheeky, Kevin. Sales as well, but yeah, we all want to get towards zero deaths. And that to do that, we need a real step change in where we are now. We have breast cancer, the most common cancer in women globally, the most common cause of cancer death in women globally, and I think it's 600,000 women will die this year from breast cancer. And it's all about early detection. We know that if we detect a cancer when it's small enough, it hasn't spread outside the breast, that basically with the correct treatments, that survival is almost near perfect. So that's a bold vision. So I would like to hear from each of you in our closing question, what do you think AI can offer to make that step change in going towards zero deaths from breast cancer? And I'm going to start with you, Brian.
Let me share one anecdote that I can't take any credit for, but it's part of the success of the broader Deep Health, and that's patient engagement is an area that is not pixel-based AI, but we've built AI in some areas of our company to help increase compliance with screening. So one of the big issues is not, there's certainly a big issue. Are we finding everything in every mammogram, and can we find more in, how do we find things early and earlier? But how do we get women in the door who aren't coming into the door? And some of our tools have shown 20 to 30% increase in compliance rates over an 18-month period, and that is affecting the population level sensitivity. It's not particularly helping the doctors per se, but that is going to help a whole lot of women who didn't ever get an image in the first place. So that's one aspect. We really need to go from 2/3 of women getting their regular screens to 100% to get down to zero.
Yeah, that's an excellent point, and it's one of the things from a compliance perspective. How do you also get them to follow up? And we have the same situation. We talk with a variety of mobile providers who handle rural and underserved areas, and if they don't get the treatment that day on that van, their chance of coming back are very, very low. So there's a variety of population health issues at hand here. There's a variety of delivery methods for the AI. Can we get all these things? And thank gosh we've had the great advance of computing power, which has made all this work. And without being able to process all the data, we weren't able to help years ago at all. So I think from ICAD's perspective, our number one solution to say is we're trying to make the world where cancer can't hide. And eliminating that to zero deaths is obviously the goal, but that takes the village, not just the single human. So, in our case, that is truly our mission is just where can we find it, and then how to treat it after that.
I guess, all of us have this success where one of our users will send us a case and say, hey, I would have missed this one. So we already help. We take credit for it, but that's very impactful. I guess so. All the AI, all of us will continue to improve. So we'll continue to find this cancer that we can miss and that a radiologist could miss. So that will we reach the 100%? Probably not, but very close, possibly. We know there is a lot of new algorithm out there, transformers that will help to be even better, for sure. And I think the other things will be also, we all talk about risk models. So can we adapt screenings depending on the risk of the patients? That would be a big thing, because then you can get some supplementary exams that are difficult to catch in mammography. So if you're a high-risk woman, you might do an MRI. So this is some area where we can help to also change the workflow for better diagnosis.
I'm not actually sure how much AI is going to change all of us will in some form or fashion impact the death rates. We'll have better sensitivity. We'll help the doctors. But I think the thing that's going to help move the needle from 600,000 deaths to 0 deaths is the democratization of healthcare and the empowerment of women in controlling their own healthcare. Today, and it's going to take a step change from where we are, right? Today, there's major problems in the way that women are treated versus men in the same healthcare. My wife and I have the same primary care doctor. If I have a cut on my pinky, he orders an MRI, a CT, I'm seeing 5 specialists, etc. She walks in with a bleeding gash on her head and he hands her 2 Tylenol and says, "You'll be fine, check in with me in 2 weeks." I mean, when women are just treated differently. When you look at breast cancer, in our country, we do the 40 million screenings a year, and women who are screened, there's BI-RADS 1, 2, 3, there's people who are screened normal. In other parts of the world, women aren't coming in for screening, they're coming in for symptoms, right? They're coming in so much later in the game, when at that point, the survivability is very different than when they're caught earlier. So even if there's AI wouldn't help that woman. You're going to have to move her earlier in the healthcare cycle and change the way that healthcare looks at women. So that's one of the things I think that's going to be a critical change that has to happen and continue to evolve is more democratization of healthcare, more women engagement and ownership of their own health and advocacy on their behalf with their doctors to demand AI, to demand deeper reviews, to make sure they're getting what they need.
Yeah, so we talked about empowering women, more engagement with them, and they should go to the doctors to request a mammo, right? But then how does that happen? I think it starts with educating women, because not many know what happens if they have a dense breast, the dense tissue with hide cancer, the cancer would be picked up later, what's their lifetime risk for getting a cancer. So I think the first step is to educate women. And that's why when women come in for a mammo, we provide like patient education material that tells them about what density they have, they have a thumbnail of the mammogram, what are the different densities, what's the risk of developing cancer, so that there is no loss to follow up. Peter talked about loss to follow up, right? If a woman knows that she's at high risk for cancer, I'm pretty sure she's going to come back again. So that's the first step to get in more women. Once the women are in, right now we have risk guidelines based on population metrics. It's high time that we need personalized risk guidelines, and to that end, we are working on image-based risk. That would be a 1 to 5 year risk, so that depending on that risk score, women can have either more intensive or less intensive screening. So you get more women in, and once they are in, you follow them up more closely if needed.
Thank you very much, all of you, for those fabulous insights. And I think we've had a really good spectrum of opportunities to get to 0 deaths: participation, engagement, as well as stratified risk-based screening, which I think is, leveraging data and AI capabilities is extremely exciting. But then also an acknowledgement that there are many cases that radiologists will feed back, "Thank you, I wouldn't have caught this." So you're all doing an absolutely wonderful job. And, it's such an exciting time. And thank you for all of your hard work in the area. And I think we're on time now. So on behalf of everyone, I'd like to very much thank all of these wonderful panelists for sharing their insights and being so generous with their time. Thank you very much.
Thanks.